Oh, sorry. Sorry, I just want to let everyone know we're recording as well, and I've just started that up. Share screen. Okay.
So I think if we can go, thanks, Tanya, through to the second slide, the next one. So what's really interesting is that in Australia, we have about 100,000 people who die each year from life-limiting illnesses. So in total, there's 160,000 people who die each year in Australia, and about 100,000 die of life-limiting illnesses, everything from, babies right through to seniors. The majority are seniors, but there is a significant core group of people with disabilities as well within that cohort. I'll talk a bit more about that in a moment. So when I first came on board as CEO 2.5 years ago, we actually looked at developing a roadmap which charted what we need to achieve to deliver palliative care, both from a health sector perspective and a community sector perspective within Australia, knowing that we've got an ageing population and a growing population. So even though I just talked about 100,000 people dying each year, we found there was a 30% increase in demand during COVID. And it wasn't actually people dying of COVID. It was people with life-limiting illnesses that weren't being diagnosed and treated and weren't being referred by community services and health services into the health system. People were really reluctant to go and see their GPs. And even if they did, there is some research that's shown that people who saw their GPs didn't necessarily follow up on the testing and the referrals into other organisations at the same time. And so this 30% increase in demand for palliative care, and when I say palliative care, I don't mean just specialist palliative care. I mean any type of palliative care that's delivered by GPs, by, allied health services, really was unable to meet that demand. And a lot of people ended up in hospital that didn't need to be in hospital, that could have been at home with community care. So we now know from the Actuarial Association or Institute that in fact that 100,000 people per year is already now at 120,000 as of 2023. And we're expecting the whole thing to double by 2040. So KPMG have done some projections which show that the number of people who will die of life-limiting illnesses will go to 200,000 by approximately 2040. So it's a massive leap. Traditionally, palliative care, in terms of our roadmap, has really focused on working with people, and the World Health Organization definition is it's actually about working with people from the time of diagnosis. So this is really interesting for social services, because social services are often told by health services that they really only provide that support in the last month of life now. And that's really more about a funding issue rather than a good clinical model issue. And in fact, it's often the social services who are in touch with the different people with life-limiting illnesses right from and before the time of diagnosis. So the palliative care model actually talks about working with people from time of diagnosis when you know that there's going to be a poor prognosis or a poor outcome. That is, that person's life-limiting condition, whether it's cystic fibrosis, whether it's multiple sclerosis, whether it's motor neurone disease, whether it's cancer, that if a poor outcome is expected, that at some point in the more likely to be those next 2 years, they will probably pass away. So if we can go to the next slide. So palliative care, when I worked in it in the 1990s for the Sisters of Mercy, was really very much focused on as soon as someone had a poor prognosis, and I was an allied health member, I was a social worker in palliative care and an educator and also a manager, we would work with the person in their home and the community service sector to provide any sort of care or support that was needed in those early days. And we might come in and out of that journey in the first year to 2 years. It was never that we were only there for the last month of life. And I worked in rural New South Wales and Victoria during that time. And the same model existed in all the cities within Australia as well. So there was generally a palliative care service that was part of the health service in almost every region in Australia. And at that time, as I said, we work with people through their trajectory, most often in the last 2 years of life, right up until death, and then for up to 2 years post-death in terms of grief and bereavement support. And that's how the state funding models and the Commonwealth funding models worked. What's actually happened since in the past 15 to 20 years is that at the state level, which is where the majority of the funding comes, it's kind of contracted to the point where a lot of palliative care services are only working with people in the last few months of life. And in many cases, some specialist palliative care services are only working in the last month of life. And that's a concern because that puts more of a burden on the community social services sector. And what that means is if you deliver disability services or child, youth and family services or aged care services, is that you are likely to have quite large cohorts of clients who actually need palliative care, but they can't necessarily access specialist palliative care. So who's providing that support to that person while they're going through this life-limiting illness? And I don't mean just personal care or housework. I'm talking about the emotional support, the clinical interventions that might be needed for pain relief or symptom control. Often in rural areas, that's community nurses, often GPs. But again, we find that our information across Australia shows that it's very hit and miss. It's like a patchwork. And leading up to the federal election recently, I met with over 60 different federal MPs, and quite a number of them said, we don't have a palliative care service in our area. So I'm very conscious, and so is our board and our members, that the burden of care is often falling onto community care services. So there are 4 different areas that we're doing quite a lot of advocacy in. One is about how we can support carers and agencies as they become involved with people who have a life-limiting illness and what that looks like. The second one is about ensuring that palliative care becomes core business in aged care, both in RACFs and aged care facilities, but also in the community. And that we've been very involved in the Royal Commission and the follow-up from the Royal Commission. The next one is about all the primary health reform going on at the moment that you might have heard about in terms of my Medicare and how GPs will become more and more involved in palliative care. And then the most recent one is about the Disability Royal Commission and what that means for people with disabilities. Because we know at the moment that there's an enormous issue. We're actually meeting with Bill Shorten's advisor straight after I present to you today to talk about this, the increase in the number of cases we're hearing about where people with disabilities are not receiving palliative care in a timely way, and in fact, or not at all. So I want to touch on all 4 of those areas. Can we go to the next one? Please, Tanya, thank you. So specialist palliative care is fragmented, as I was talking about. Specialist palliative care all over, well, it's actually not all over the world, but many parts of the world is actually a clinical medical specialty, but it is holistic. It is looking at symptom control, pain management, but also social and emotional and spiritual support. And it won't surprise you to know that the majority of palliative care providers in Australia are Catholic. Or religious-based providers, because they're able to provide often that spiritual support component. So we know there's fragmentation. We know that we're working towards a local hospital network-led multidisciplinary approach, which includes specialist palliative care and supported by community services. So there's still some way to go in thinking about your state bodies that fund you, as well as DSS, on what the role looks like. We're currently, providing input in updating the National Health Reform Agreement to talk about statements of roles and responsibilities in relation to palliative care and commitments to provide timely access to healthcare services for people with life-limiting illness. Can we go to the next one, please, Tanya? So palliative care and aged care in Australia, and this is going to shock you, I think you probably would expect that the majority of people who live at home, who are seniors or are in aged care facilities, actually are assessed as requiring palliative care. So here's the statistics from AHW. There were 53,000 deaths in aged care facilities in 2022. Of that, 53% had high complex health needs, but we know that less than 4,000 people were assessed as needing palliative care. So there's 53,000 deaths. but less than 4,000 received palliative care in aged care facilities. So we know we have a long way to go. Another really interesting statistic is that in aged care facilities, over 95% of people die in the first 22 months, less than 2 years. So therefore, if their aged care facility is their home, they should be receiving care and support in order to die in that home rather than being shipped off to hospital. And interestingly, when you saw that ambulance ramping happening in Victoria during COVID and beyond COVID, majority of those people on those ambulances were actually seniors who were symptomatic. So instead of having community-based services being able to come in and provide that care support at the level that's required, people, every time they became symptomatic, were going off into the hospital system. So we have a lot of work in terms of ensuring that we embed palliative care in aged care facilities. Next week is the Aged Care Conference in South Australia, and ACPA, the peak, has asked us to come and be part of a panel to talk about how we embed palliative care in aged care. So it's not just about the new funding instrument, which through My Aged Care and the assessment, the ANAC model, which provides for only 3 months of palliative care. Very hard to tell if people are only going to live for 3 months. And there are some systemic issues around how do you have that renewed every 3 months. There's provision for reassessment, but how that actually happens in practice is another issue. So making sure that all staff are actually trained in palliative care is another need in the aged care system, because pretty much the majority of people that your staff will work with if you deliver aged care services will actually require palliative care at some point in that journey while they're with you in your service. Can we go to the next one, Tanya? So the aged care pricing didn't adequately fund palliative care and aged care. As I was saying, it's actually about having enough assessors. We're asking for, in every time that someone enters into My Aged Care, that there is a mandatory assessment for palliative care if they're going into an aged care facility, particularly because the average age of people entering into aged care facilities now in Australia is early 80s. And so majority will have a life-limiting illness. If not more than one, they'll have two. We're asking that beyond the amount of care that's provided each day, that to deliver palliative care, it needs to be a holistic team as well. And similarly in community care. So we also are making sure that we advocate to ensure that new home care program will encompass palliative care as well. Next one, thanks, Tanya. And by the way, when we've finished all this, open to any questions. Also, I don't talk about voluntary assisted dying in this, but actually open to talk about how the rollout of that is going and the implications for palliative care and community. Disability issues. So there was no mention of palliative care in the Disability Royal Commission final report. We did do a submission, but what we found out is that the immediate problem is the changes to keeping people under 65 out of residential aged care. So we've met with a number of different senior level executives in the Department of Health and Aged Care at the Commonwealth level to talk about the number of people with disabilities under 65 who are still in aged care facilities. And I don't know if you've noticed, but they've been gradually transitioning them out in the last 6 months. And their goal is to transition them all out over the next year or so. But where are they going to go? And where's an appropriate place? And is that hospital, or is that purpose-based built facilities or homes, or what does that look like? So we've started exploring that with them, because the Department of Health and Aged Care is really concerned about the number of people under 65 who are becoming part of the aged care system and the cost to the aged care system, but where should that sit? Interestingly, when we met with the NDIA recently, one of their executives, they had said that for people with disabilities, they only consider that palliative care will come into train in the last 12 months of life. So that's their definition. Now, if you've already got an NDIS plan and you develop a life-limiting illness, then your NDIS plan will continue in theory, and palliative care should be coming in to provide the clinical support. However, there's some confusion here, because when we spoke with one of the other senior executives of the NDIA, they said there's no 12-month rule on this. So you have different parts of the NDIA with different messages around this. So that's one of the reasons we're meeting with Bill Shorten's advisor today. So we really have this no man's land of where people with disabilities under 65 currently sit in terms of receiving health support and community care support when they have a life-limiting illness. Interestingly, we've been talking to a whole bunch of other stakeholders, including in the cancer sector, neurological sector and childhood dementia, and all their cohorts are being affected. They're all finding it difficult to access timely quality palliative care for their clients. And remembering that social services are often the primary start of referral. People often think it's GPs, but it's actually community care organisations who usually identify with people when their health is starting to deteriorate. And there's actually very few formal referrals that are done by community services. But knowing that in health, referrals can come from community services, from care workers. It doesn't have to come from necessarily initially from a health provider. And quite often, people with profound disabilities don't always visit their GP regularly. And as we know, many GPs don't do home visits. And so how do you ensure that somebody with a disability, particularly a physical or developmental disability, is able to access GPs in a timely way? And how do your care workers provide that support for that to happen? So we are going to address the issue at the upcoming meeting of the Disability Reform Council. Don't have a date on that yet. We do want to see an established dedicated team in the NDIA to actually nut out this problem about how we're going to work with health to ensure that there are warm referrals, that there is a properly set policy space and funding space for people under 65 with disabilities who are palliative, which we're talking in the hundreds of thousands here. We're not talking small numbers. Can we go to the next slide, please? Thanks, Tanya. So primary health. So specialist palliative care has emerged as a term. Palliative care was that we worked with all patients and clients, and we were involved in anybody who had a diagnosis. The way that the Commonwealth Department of Health and the state governments have moved is that specialist palliative care generally tends to work with people with complex diagnoses now and provide advice to care workers, provide advice to GPs, provide some clinical support, but the bulk of the care is still actually done by community care services and health services. So I just wanted to let you know that we're really keen to ensure that GPs are also trained and skilled to ensure that they are working within a system of trying to identify people's life-limiting illnesses and provide that support throughout their care journey. It may not surprise you to know that not all GPs are interested in palliative care, and not all of them understand it. They only get something like half a day of training in their entire medical degree. So this is not something that all GPs are across. But the ones who are and are involved in it, they're usually fantastic. Can we have the next slide, please? So children and young people, as I mentioned to you right at the beginning, my last position as CEO was CEO of a child, youth and family organisation, and we saw about 17,000 children and young people a year. Of that cohort, many of them had to go up to Sydney or down to Melbourne to receive their paediatric palliative care services. There's only something like 4 paediatric palliative care services in the whole of Australia at this stage. So majority of children who receive care are actually going to general paediatric wards in hospitals, not specialist paediatric palliative care. We found that the majority of children we were working with in foster care or in out-of-home care circumstances, or who were in very stressful family situations, who did have life-limiting illnesses, often didn't have comprehensive wraparound health services, and that the referrals for kids, particularly kids who had developmental disabilities and other diagnoses such as cancer, cystic fibrosis, or other life-limiting conditions, often got referred very late, they and their families very late, to palliative care. And if you can imagine, particularly for those of you who are providers for child, youth and family services, that when you're working with children at different developmental stages, working very early with the parents or the carers and the children and their siblings is absolutely critical to a successful outcome in that care journey. So one of the reasons I really wanted to connect with you all today was to provide that understanding that for those of you who work with children and young people, you're often a key link in the service cycle of how you can have children and families referred early to start receiving palliative care support. Can we have the next one? Thanks, Tanya. So training, at the end of the day, if we look at the whole of the health and community care sector and what training is involved, there's very little palliative care training embedded in Cert 3, community services, Cert 4, in RNs, in allied health, in medical qualifications. And so the actual number of people who work in palliative care, we have a workforce issue, like most areas of health and community services. We need to have more people trained. But what we're also saying is we need to ensure that community care workers also have embedded in their qualifications core training in palliative care, given that all of them, 100% of them, will at some point in their caseload work with someone with a life-limiting illness. And so we've been providing some input into, and I think the Prime Minister made an announcement yesterday about a new skills package that they're going to fund. We want to ensure that we start to embed this end-of-life care thinking. I always use the analogy, you wouldn't bring a baby into the world without support, without having prenatal classes, postnatal classes. Why would you be expected to go towards your end of life without support and care? So it's part of our workforce development strategies to ensure that we have this training embedded across all these qualifications. And that's part of the key to the solutions that we're looking for. So, Tanya, I think that's the last slide. And I just really wanted to have the opportunity to have time to talk with you all about, or ask any of your curly questions, and anything that you feel has been happening, whether it be about voluntary assisted dying or questions about that. So look, any questions that you might have are very welcome.
Well,
Tanya, if you could stop sharing the screen, that would be good.
Oh, sorry.
That's all right. Then I can see everybody. Thanks.
There we are. That's better. Great. Siobhan and Karen and Jenny, do you have anything that you'd like to query or discuss?
I guess one of the questions I have, does any of this surprise you? Has anything I've just mentioned to you new to you? No. So in terms of the disabilities, I think what we were surprised by was the number of people with disabilities who are not being referred to palliative care by community services, because often it's the only community services are involved in that household and nobody else. And the number of people who are falling through the gaps. I think we were really surprised by that. We weren't surprised by the aged care information. I think the Royal Commission, said that there were 14 recommendations all relating to palliative care. It's a bit of a no-brainer that we know the majority of, particularly of those of us who work in aged care, we know the majority of people who are seniors accessing my aged care packages will need to have palliative care at some point.
Oh.
I feel like
I am interested in hearing you. You said you were going to talk a little bit about where voluntary assisted dying fits in with that.
Yeah, so it's very different in every state across Australia. The laws are different and the way it's administered is different. It's not a nationally cohesive group of rules and regulations. It's interesting because you would have seen that Go Gentle, which is Andrew Denton's organisation, was a great promoter of voluntary assisted dying a few years ago, and most of you will know Andrew Denton's a very eminent journalist. Andrew is now at that position where he said he believes, because of the course of the time he did this, is just around the time his father was dying and died, which is of course an intensely emotional time. And he was sort of going, voluntary assisted dying at all costs. Don't worry about palliative care. Whereas now he's actually at a position a few years down the track where he's going, do you know what? We actually need to have the option of palliative care for everybody. And what I was saying to you before, that patchwork of palliative care services across Australia now means that it's not available to everybody. So we're still advocating to say that our position statement is what people choose to do at end of life is their own personal decision. But people must have the choice of palliative care, because we know through some research that's already been done about people who have registered for voluntary assisted dying, that those who've received really good quality palliative care actually choose not to go through with the voluntary assisted dying. So they overturn their decision. So at any time in their journey, once someone's made that decision to register and have voluntary assisted dying, they can change that decision right up until the end. And our position is that people should be able to, regardless of what their choice is, they should be able to access good quality palliative care right throughout. I think some of the challenges are that people who are very strong proponents of voluntary assisted dying actually wanting to see an integration between palliative care and voluntary assisted dying. And I think that's problematic because they're actually two very different models of care. So we're saying they can coexist where services choose to deliver voluntary assisted dying. So some palliative care services do, then they can coexist. But they shouldn't be integrated in as one service at this point out. That is not our position. So there was recently a voluntary assisted dying conference in Sydney a couple of weeks ago, and they started talking about the importance of this integration. I think that would be unfortunate at this point of time. We've got a long way to go in our evolution as a nation. And in other countries such as Canada, where they've started to look at this integrated approach, the numbers of people choosing voluntary assisted dying have gone up through the roof, particularly if they can't access palliative care. So I think it's problematic. There definitely are some palliative care physicians and doctors who do deliver voluntary assisted dying as well, but the majority, my understanding is the majority of practitioners who've registered to deliver are doctors from other specialties and other areas. And it's not an easy process. I think some of the controversial things that have arisen this last year, and sorry, Karen, I'm probably going beyond what you wanted to ask, but tell me to stop if it's too. So one of the things is that people with dementia. So how are they able to be involved in making that decision? And at this stage, it would only be in the early stages of dementia that someone would be able to choose to have voluntary assisted dying, because they're still in that capacity of being able to make those decisions. There are some parties who are seeking to have people with dementia be able to make those decisions even further into the trajectory of their illness. So that's an interesting one. ACT is currently looking at its own putting its own legislation together. And they, at one point, were looking at people under 18, children and young people being able to choose to have voluntary assisted dying. I'm pleased to say they've taken that off the table now, and I think that would have been really problematic if they had continued down that path. Yeah. So are there any specific things you wanted to know, Karen, about it that I can help you with?
No, I think I guess it's just like, say this is more about an overview and statistical information and those kind of things. And I think that it's poorly understood, the differences, and I think extremely problematic that this is an ongoing problem in terms of almost everything that of some importance is that they have different legislation in every state. So it's an ongoing problem, really.
Yeah, and in fact, Central Australia and Northern Territory are just starting to bring their groups together to talk about, over the next couple of years, what they might form in terms of legislation. Because you might recall that in the early 2000s, Philip Nitschke was successful in getting euthanasia bill up in the Northern Territory. What I hadn't realised until I visited there and spent some time there in April this year was the trauma that caused in the Northern Territory that still exists 20 years later. So apparently there are still people from rural and remote communities who won't see doctors or go and visit clinics that were proponents of the euthanasia bill back in 2002. There is still stigma attached to people who are interested in euthanasia or voluntary assisted dying, if they choose to go down that path. There's a very negative sentiment about euthanasia or voluntary assisted dying in the Northern Territory, particularly amongst rural and remote communities. So that's 20 years down the track. And so when they develop their legislation, they're going to have to take that into consideration. Particularly for Aboriginal and Torres Strait Islander people. And I was actually talking to someone from WA recently who said that the stigma is so strong, particularly within Aboriginal communities, that many people who think that they would like to choose VAD actually move away from their community and their families and their supports to go and have VAD delivered in Perth, away from their rural and remote communities, because they're worried about the backlash on their family from the rest of the community. I thought that was really telling. So that's WA. Was there anything about that move from, I think it was you, Karen, or Jenny, who said that, people are not really aware of the difference between voluntary assisted dying and palliative care. Do you think that within the states that you work in, that the community sees enough information about what palliative care is? Because we've had some pretty big campaigns. Have you personally seen television ads and information out there in your communities? Jenny's going yes. Siobhan's going no. Whereabouts, Siobhan? Whereabouts are you based? Or sorry, I couldn't hear that. You're on mute. Yes, yeah, okay. So Palliative Care Queensland's had some pretty big campaigns, but you're saying there probably needs to be more information. You haven't seen a lot of information out in your community. Would that be right?
Sorry, I just came off my headphones. I think I haven't seen anything. I've recently been to the movie Live the Life You Please, that played about 3 or 4 months ago. And that was interesting from the perspective of the differences in the types of services that are offered. And that was put on by the palliative care team from the hospital. And it was very much, oh, this is great. And they're like, yeah, we just come in the last few months. We don't offer, and the movie talks about that 1 year, 2 year assistance. I like where you're going with the discussions with Bill Jordan around a team specialising in palliative care for NDIS. And I think we get that backlash of, oh, that's the health system. No, that's NDIS. No, that's the health system because we work in disability. So it'd be good if there was a team that would actually specifically look after those plans. And work with the supports around what is health, what is palliative. But I think they're going to have a really good understanding of what's available in the region. because there's no point saying, oh, that's health, and the health system here doesn't provide that to our communities.
Yeah, thanks, Siobhan. And Karen, whereabouts are you based?
I'm in Wagga.
Oh, that's my old area.
Hmm.
Yep. Okay, yeah. So I used to work in the Mercy team, but based in Albury, and we used to provide, I don't think they provide outreach commonly up to Wagga now. I think it's mostly done by Calvary. But yeah, okay, great. Excellent. And Jenny, whereabouts are you?
Hi, we're in Central Queensland.
Yeah, awesome. So Karen and Jenny, Jenny in Central Queensland, and I lived up in the Darling Downs for a couple of years, 20 kilometres outside of Dalby. The closest palliative care was Toowoomba at that point of time, and there was a little bit of outreach, and we're talking about, 17 years ago here. But do you find where you are that you have palliative care services in your region?
We have nurse navigators that connect us into the palliative care team. We used to have palliative funding through Queensland Health in Emerald. That's no longer the case. So yeah, we're basically linking up through whatever media we can, pretty much.
Yeah, got you.
Telehealth and the nurse navigators and the community care programs like ourselves, we help to coordinate all that with the clients.
Yeah. Okay. So each of you in rural areas where you've got really, hopefully quite strong primary health networks, are you aware that the primary health networks have been funded for a few years to look at particular models in your regions for palliative care and how that can coordinate better? So I'm just thinking, I'm really familiar with Karen's region. But yeah, just so
I think one of the providers has obtained that funding through the PHN.
Yeah, okay, great. Because the Commonwealth Government had really thought about in rural regions, and look, it's all over Australia, but particularly in rural regions, how do you have something that's place-based that actually meets the needs of your particular region and surrounds? Like Wagga's, for example, a major regional centre, but services extend right out, a couple of 100 kilometres around Wagga. So, what does that mean for the primary health network in Wagga and in terms of how they're using that Greater Choices program? So if you ever get an opportunity to meet with your primary health network and ask them what they're doing with Greater Choices in your region, I think that would be great for you to be able to sort of see how they're trying to work to improve palliative care access in your region. Yeah. Okay. Anne, you're with the CSSA team, aren't you? You're not out in a Catholic social service.
I am. Yes, correct. I was just thinking, Camilla, how with all the different, I suppose there's no harmonisation in the way the care is rolled out. Is there any information that you'd like us to facilitate to our members that might help them in just finding their feet around all the different sort of rules around palliative care and until such time that there's a legislation that harmonizes this?
Yeah, on our website, there's some really excellent resources that you could send electronically around to your members about what palliative care is, how it supports carers. And then we've also got all our different policy submissions. You could even provide them with links to the website and just say, if you're interested, for example, I think it was Siobhan who was talking about people with disabilities.
Yeah.
If you're interested in seeing what our submission said around the issues for people with disabilities, that submission's up on our website. So there's some really good basic information about what palliative care is and what it should look like in terms of the models up on our website that you could use. Yeah.
Great. We will. We might download some of those and also put that across into our resources there is on our website for members, because we've got a dedicated area for resources for members to access.
Yeah, excellent.
We might.
Terrific.
Thank you.
All right. Well, Tanya, if there's no further questions, should we wrap it up?
Yes, if everybody's happy. Thank you so much. I know I've certainly learned a great deal today about what's happening around the country. And like with all these things, it'll be nice when everything can be harmonised statewide, so it's not so complicated for everybody. Thank you for coming, guys, to our little group. We had quite a few register, but it doesn't always turn into what people can
Understood.
do on the day. Yes, but
Understood.
thank
I
you.
used to be a member of CSSA. I completely understand. And if you've got a, you know, this recorded, then hopefully, you know, the people who weren't able to see can see at least scroll through some. But happy for you also to send that presentation out as well. That PowerPoint.
Oh, thank you so much. I was going to ask you off here. Yes, that would be very helpful. Thank you. And as Anne said, we've got our members resources page on the website. So everybody's welcome to go in there and have a look, and we can add things like this to there as well.
Terrific. Okay. Thanks very much.
Thank you so much.
Everybody.
Thanks everyone. Bye-bye.